Thank you everyone for joining this afternoon to talk a little bit about monochorionic twins. Some of you maybe are joining us on the same time for a case conferences, but this is going to be a little different. We're going to specifically talk about monochorionic twins. I'm going to present a little bit about the disease, and then I'm going to hand it to Dr. Didier. She's a pediatric radiologist here at Boston Children. And then Dr. Ronai, a pediatric cardiologist, will help us understand a little bit more about fetal echo in this disease. We're focusing during our talk in twin-twin transfusion syndrome, but we'll leave the part at the end for discussion where we can open up a little bit more about selective fetal growth restriction or TAPS if you would like to. We couldn't cover all of these fields in 40 minutes, so we decided to focus on twin-twin. When we're talking about monochorionic twins, twins that share one placenta, we know that there are specific complications associated with the fact that they share a placenta. The most common one, twin-twin transfusion syndrome, seen in about 12 to 15% of those cases. Selective fetal growth restriction is the second most common complication, seen in about 12% of those cases. And we have other issues that are more specific to monochorionic twins, such as higher rates of anomalies, twin reverse anemia, polycythemia, and TRAP and TAPS. I mixed them a little bit. But when you look at this placenta, you can see the entire pathophysiology that is causing twin-twin transfusion syndrome. So the blue dye here are those would be the arteries. We know that because they go over those yellow ones here and over those red ones in this side. So the blue ones would be the arteries, the red ones on the right side would be the veins, and on the yellow ones on the left side would be the veins of the other twin. We see that there is an area in between those parts of the placenta that those vessels meet. Or as I tell the patients, imagine those two cords going into the placenta as two trunks of a tree. The roots of those cords are meeting on the placenta. And you can see different types of connections in that area that we call the vascular equator. You can see some that are artery to artery, as you can see here. You can see some that are artery to vein, as you can see here. And occasionally we also see vein to vein. But the most common ones seen in twin-twin transfusion syndrome would be the artery to vein anastomosis. I want to emphasize that those types of anastomosis are seen in all monochorionic placentas, but in twin-twin transfusion syndrome, for some reason, they are not balanced in a way that blood flows from one twin to the other, and there's a net flow from a donor twin that we call to a recipient twin. And what happens is the donor twin, first we see two amniotic sacs that are relatively balanced, but something happens, and you see that there's a net flow of blood towards one twin, and then we see less and less fluid on the donor side because the donor becomes dehydrated. We see more and more fluid on the recipient side, which is overhydrated. 16 weeks and on in pregnancy, the fluid around the fetus is mainly urine, and since the donor twin is dehydrated, produces less and less urine, there's less and less amniotic fluid around that twin. The other one is overhydrated, produces more and more urine and more and more fluid around that twin, until a situation that we get a stuck twin, or one that has very low amounts of amniotic fluid on one side, that's the donor, and the other one that has a lot of fluid on its sac. We know that it's a major issue. We know that twin transfusion syndrome or severe twin transfusion syndrome that we define as stage 2 and above, and I'll get to the staging system in a moment, has a poor prognosis without intervention of about 90% chances of losing the entire pregnancy. The staging system is a relatively old system that was presented over 20 years ago, 25 years ago, by Quintero, and it uses very basic ultrasound parameters that we're taking when we're evaluating those fetuses. Stage 1 is when we have the polyoligo between the twins. The donor twin has less than 2 centimeters of fluid, and the recipient twin has more than 8. So once this is met, we're at stage 1. Stage 2 is when the donor twin is so dehydrated it doesn't even feel its own bladder. And not only that we have this polyoligo, but we cannot demonstrate the bladder in the donor twin. Stage 3 is when we start seeing abnormal Doppler flows, and the abnormal Doppler flows are defined by absent or reversed end diastolic flow in the umbilical artery of either twin, and absent or reversed A waves in the ductus venosus of either twin. Usually, you'll see the UA anomalies in the donor twin and the DV anomalies in the recipient twin, but not 100% of the cases. Stage 4 is when the disease is so advanced that we start seeing high drops, usually in the recipient twin. And stage 5 is when we were too late and we got a demise of one or both twins. Okay, at this point, I'm going to hand it over to Dr. Didier to go through some of the imaging.
So I'm just briefly going to cover how we image these patients, both with ultrasound and MRI. We'll start with ultrasound. First off, we want to confirm that it truly is a monochorionic diamniotic pregnancy. That's kind of the first step. But we'll look at the placenta, cord insertions for both babies. We'll look at fluid, bladder filling, Dopplers, including the umbilical cord, ductus venosus, as well as the middle cerebral artery. And then we'll also assess fetal growth. And we also want to kind of do our routine anatomic evaluation as well and make sure there's no anatomic abnormalities in these twin pregnancies. I'm a radiologist, so we're going to focus mostly on pictures to describe how we evaluate these patients. So here's just one example, monochorionic twins. We're first going to look at the fluid in baby A. The deepest pocket here is 3.3 centimeters. 2.0 is going to be our cutoff. So we're above 2.0. So our fluid right now is low normal. And the DVP in twin B is over 8, which is our cutoff for polyhydramnios. So we've met criteria here for polyhydramnios with the deepest pocket of 8.3. We're going to look at the bladders in both of our twins, and we see nice fluid-filled bladders in both of them in this case. And we're also going to look at our Dopplers, which you can see here on either side, and I'm just going to tell you that they're normal. So at this point, we have what we call an amniotic fluid discrepancy or discordance because we haven't met criteria yet for oligohydramnios, so kind of plus minus. Everything else is good to go. And the overall discordance in the weight between these fetuses when we look for our growth restriction is 14%. So no severe growth restriction at this point, and this patient is at 20 weeks. We obviously follow these patients very closely because things can take a turn for the worse pretty quickly. So amniotic fluid discordance here, and we bring the patient back 5 days later. And now we can see when we measure that deepest vertical pocket, it's 1.6. So we're below our threshold of 2.0. So we now have oligohydramnios in twin A. And we have worsening polyhydramnios in twin B with the deepest vertical pocket of 10.1. We still see fluid in both baby bladders. And I'm going to tell you that the Dopplers were normal. Obviously, no difference in the weight over the course of the last few days. And this now meets criteria for stage 1 twin-twin transfusion syndrome. So that's our kind of straightforward kind of progression of TTTS in these twins. Here's another case example. We're going to do exactly the same thing. We're going to have a deepest pocket of 1.0, so oligohydramnios in twin A, and we have polyhydramnios in twin B with the deepest pocket of 8.8. At this point, we are unable to see any fluid in the urinary bladder in twin A. So this is different from our last case where we were able to see a bladder. And then in twin B, we see a nice, well-distended, fluid-filled bladder. You'll look at the Dopplers, the UA in these babies was normal, DV and A was normal, but there is some abnormality of the ductus venosus in B. So there's kind of borderline Doppler changes at this point. So we have, our poly-oly sequence, we have absence of fluid in the bladder, and then kind of borderline Doppler changes. And this is kind of stage 2 moving towards stage 3 TTTS. Another case, again, same pattern, same thing we're looking at. We have polyhydramnios in twin A, deepest pockets 13.5. We have oligohydramnios in twin B, it's less than 2. Big fluid-filled bladder in twin A, we do not see a bladder in twin B. And then when we're looking at our Dopplers in twin A, the recipient, you can see there's absent of end-diastolic flow and a little reversal. There's reversal of flow in the ductus venosus, and we have a very pulsatile and even reversal of flow in the umbilical vein. So very severe Doppler changes in these babies. So we've now met criteria for our poly-oly, absent bladder, abnormal Dopplers. Obviously, we're not done. We're going to go looking around, and you can see here in this sagittal image through the fetal chest and abdomen that we now have development of ascites in twin A. So we have moved on to developing hydrops. And going back to how we always look for anatomic abnormalities, the brain is one of the biggest concerns in these babies in terms of complications and morbidities. And you can see this echogenic area in the fetal brain on the left, which corresponds to an area of hemorrhage on our MRI EPI sequence. So we've had kind of sequelae of very severe TTTS. So we've got hydrops. I'll let you know the MSEd Dopplers were normal, and there's actually concordant growth restriction at the same time with a discordant weight of 21% between the fetuses. So this is stage 4 TTTS, which is complicated by hydrops and brain abnormalities in twin A, but there's also donor fetal growth restriction. And I think that this kind of speaks to, as we get into our next case, there's often a lot of overlap between a lot of the things that we talk about with these twins. It's not always perfectly aligned 1, 2, 3, 4 TTTS, and then everything else separate. There's a lot of overlap. And I think this case will showcase that pretty nicely. So we, again, have oligohydramnios, polyhydramnios in twin B, fluid-filled bladders in both. So we have what we see as amniotic fluid abnormalities with poly-oly, but we see bladders and the Dopplers are normal. There's no hydrops. So this is stage 1 TTTS, but as we've shown, we still have to go looking around. When we look at the MCA Dopplers in these babies, for fetus A, it's about 58, which corresponds to a multiples of the median of 1.99. 1.5 is our cutoff for abnormal elevation, so we're above that here. And when we look at baby B, we see that the multiples of the median of that median of the MCA is 0.5. So there's also a big discrepancy between the two babies. We're obviously not talking too much about other complications besides just the TTTS today, but this is just to show you that we also look at the MCAs and we can have concomitant abnormalities in the middle cerebral arteries as well. And in this particular case, there was also donor growth restriction with a discordance between the twins of 31%. So this case kind of shows a little bit of everything in terms of the complications that we have with these twins. So stage 1 TTTS, which we've shown here by the poly-oly, there's donor growth restriction. And then with the difference in the MCAs and the elevation in twin A, there's also a component of TAPS. So I think this is a good case example to remind us that it doesn't, these cases very rarely follow the rules, and we have to be looking for a little bit of everything. So that's sort of our ultrasound imaging evaluation. And then by MRI, which we are fortunate to have a very robust program here, and we've been able to use MRI to look at these twins as well. And we can use MRI as a complementary imaging modality. Again, we're going to confirm that the pregnancy is truly monochorionic diamniotic. We'll look at the fluid around the babies subjectively. We'll look for bladder filling. Again, any anatomic abnormalities, MRI really helps us a lot in seeing the fetal brain in ways that ultrasound sometimes can't. And we'll also, again, evaluate the placenta and cord insertions, another benefit of MRI. So here you can actually, the membranes are very thin, but you can often see them on MRI. So you can actually see the membrane separating these twins here, and you can get kind of a subjective assessment of the amniotic fluid around the twins here. We'll obviously be able to see a nice fluid-filled T2 hyperintense bladder in these babies. And then again, we'll look at the brain. And so here's just a couple examples of being able to kind of look inside the calvarium at the central brain structures and look for any abnormalities like bleeding or just kind of anatomic abnormalities as well. And then when it comes to the placenta, I think there's a lot that we don't know right now, but we're hoping to acquire a lot of information with our MRIs as we image these twins pretty regularly. You can see the anterior placenta here, pretty, homogeneous T2 hyperintense signal. And what you'll notice here when you look at the T2 star weighted image, which is a specific sequence that looks for things like blood and oxygenation, you can actually appreciate, I think even visually, that this part of the placenta associated with one twin has different signal characteristics than the placental component associated with the other twin here. So I think that there's a lot that we can learn from MRI about these twins that we aren't able to appreciate this sort of kind of these changes as well on ultrasound. And I think there's a lot of information we can gain from our MRI. And last but not least, we can use MRI to assess, fetal well-being as well, as you can see with these cine clips. So we can assess fetal motion as well as the other things that we've already talked about. So here we use both ultrasound and MRI to evaluate these twins to kind of lend to the diagnosis so that our surgeons can make the appropriate recommendations and treatment planning.
Thanks, Ryan. I would say whenever they are referred to us, even if they're referred at 15 weeks, we'll do Dopplers.
Yeah.
We'll take it with a grain of salt that early, but still we'll do it.
Yeah, I think the interpretation is sometimes a little bit limited because the charts don't go that low, but I agree, we image and do Dopplers whenever they're referred in to us.
Okay, so after hearing about the diagnosis, how can we treat the disease? And let's go through that a little bit. So years ago, the treatment would have been just reduce the fluid or even create a hole between the intertwin membrane, a iatrogenic septostomy to kind of balance the fluid between them. But nowadays, the treatment of choice, the gold standard, is fetoscopic laser photocoagulation that was shown to be superior to any other treatment and is the treatment of choice when we're talking about stage 2 and above. Might also be relevant to stage 1, and we can, if we'll have time, we'll talk about that later on. We know that from different studies, both randomized control studies and many other retrospective analysis, after laser, we're talking about 90% chances of having at least one twin alive at birth and about 70% chance of having both twins alive at birth. That's when you're taking all of those cases together without sub-analysis of staging or other components that might affect the risk of the surgery or the overall progression of the disease. And that's definitely quite different from what we know or described earlier of about a 90% chance of losing the entire pregnancy with no intervention. Short video of how this looks like when we're in the surgery. So we're diving in with our small camera, the fetoscope, into the area that I showed you before, that the two sides of the placenta meet, or what we call the vascular connection. We diagnose those connections and we coagulate them with laser. That's when you're seeing this whitish area appearing. That's when we're coagulating. This is a good example of a meeting of those two vessels where we can coagulate them. After we're going from one edge of the placenta to the other edge of the placenta, coagulating all those dots, sometimes we'll choose to connect those dots with what's called solemnization. Solemnization a few years ago was very commonly done and was practically done in every case, as it showed that post-laser complications such as post-laser taps are much lower, assuming that there are connections that were missed when just doing the selective lasering. But now we know that it's not necessarily the best choice, since our fetoscopes have improved significantly. We have a better resolution now. And if we see a completely bare area with no connections on it, with no doubt, we would avoid doing the solemnization there. So kind of a modified solemnization, because we know that all this energy brought on the placenta is also associated with complications such as placental abruption. The challenges that we're still facing when we're talking about laser are, first, stage 1 twin transfusion syndrome. Do we offer an intervention at stage 1 or not? We know that about 40% of stage 1 will either remain as stage 1 throughout the pregnancy or even regress. However, 60% progress. We also know that those that progress, if compared to an earlier laser, will have a worse outcome. So it's kind of a balance between going in earlier to sitting and waiting on it. Definitely when we have patients that are not from the area, that have had to travel from a long distance and cannot be monitored closely at stage 1, we will offer surgery. Also, if there are additional complications such as shortening of the cervix because of this polyhydramnios, or the mom is uncomfortable with symptoms, we will offer laser as well. Other challenges that we have with lasers are if the patient had prior bleeding. A drop of blood in that amniotic fluid will color everything, and it will make the surgery very difficult to complete and see the connections. Anterior placenta proceeds to be a challenge, as when we enter the placenta, the uterus, we cannot enter through the placenta. So we have to find an avascular area around the placenta, and then we also need to look up into the placenta. So it makes it more technically challenging. If the cords are very close to each other and large vessels are going straight from one cord to another, we might not be able to coagulate them. And also a challenge is if the patient presents already with a very short cervix, adding this layer of intervention just increases the risk of premature rupture of membranes and complications. We've done quite a few studies to address those questions. We addressed the problem of pre-op assessment. We are currently basing our whole management on the Quintero staging that, as I mentioned, were established 25 years ago. We have many more ultrasound parameters today. We have fetal echo that you'll hear about soon, and we have MRI that is not at all incorporated into the staging system. Also, it's sometimes hard to tell the patient what is actually going to happen. It's true that we're quoting those 90% chance of having at least one twin alive and 70% chance of having both of them alive, but it's not necessarily true to our specific patient, which has a more complicated situation, for example. So we try to come up with better predicting tools of the survival. How do we deal with an anterior placenta? What do we do with the complications? The most common complications are chorioamniotic separation and septostomy, where the membranes are no longer adherent to the uterine wall, tinted from the inside of the uterine wall, increasing the chance of premature rupture of membranes, or septostomy, creating a hole between the twins, now being in one amniotic sac or iatrogenic, monochorionic, monoamniotic with cord entanglement problems and other issues. And what do we do when we have a very early twin transfusion syndrome before 18, before 16 weeks, or a very late one after 26 weeks? As for the pre-op assessment, there have been several classifications that have been offered. Most of them are focused on cardiac manifestations, fetal echo. They have failed to establish a new or an accepted staging system. And I think the main problems were one, the lacking of correlation between the preoperative cardiac function that we'll hear about soon and the actual perinatal prognosis. We know that Quintero staging goes hand in hand with the prenatal prognosis. Stage 1 is better than stage 2, stage 2 is better than stage 3, etc. As for now, the parameters that were offered by fetal echo are not necessarily going hand in hand with overall outcome. It is also technically challenging, and not all institutions can offer a complete fetal echo. So it's not necessarily something that is applicable to all centers. But let's hear about that a little bit more from Dr. Ronai now.
So yes, thank you for the opportunity to talk about the cardiac manifestations. So as we sort of talked about, the complications from monochorionic twinning can include TTS, TAPS, TRAP, selective growth restriction, and prematurity. Importantly, monochorionic twins can have an 11 to 13% risk of congenital heart disease, and it is highest in those twins with twin transfusion. Most of the risk is due to acquired pulmonary stenosis. However, the cardiac manifestations can appear even in the early stages in terms of a recipient twin cardiomyopathy. The pulmonary stenosis can develop in about 5 to 10% of twin transfusion syndrome cases. So here you can see what we assume to be the recipient. And you can see here the right ventricle is very hypertrophied. It's not squeezing particularly well. The left ventricle also doesn't look particularly fabulous. And so you get a sense of the cardiac hypertrophy. There's diastolic function pathology, declining systolic function. And then we're going to get into the right ventricular outflow tract problems. You can get aortic pulmonary size discrepancy. And then in about 40% of cases, there's tricuspid regurgitation. Here's a nice example of the pulmonary valve is right here. So this would be your superior vena cava, your aorta, and here's your pulmonary valve. And you can see that it's very thickened and dysplastic and not really opening particularly well. This is a nice example from our center at around 16 weeks in the recipient twins. So again, you can see that there's a decent amount of fluid, similar to what Dr. Didier was talking about. And let's see if we can make it play one more time. It's getting a little glitchy. But here, as you look, you can see anteriorly, again, that right ventricle is not squeezing very well. And as we get all the way up here, you again get a sense of that right ventricular outflow tract not being quite normal. When we put color on, you can see that RVOT is actually not really opening at all, because blue is away from the Doppler. And so you can see that that's actually all being supplied by the ductus arteriosus. So there's currently functional pulmonary atresia in this 16-week fetus. And then here is severe tricuspid valve regurgitation in the same fetus. And then this is the second echo after intervention, but here you can see that the right ventricular outflow tract is entirely open, and we now have appropriate antegrade pulmonary blood flow and no longer getting retrograde filling via the ductus. The other thing we spend a lot of time on when we do our pre-intervention assessment for twin transfusion is looking at the AV valve inflow. So normally it's biphasic with an E and an A wave. In fetal life, it's always a dominant A wave and a smaller E wave, which is the reverse of what happens postnatally. reflecting the fact that there is reasonable diastolic dysfunction in the fetus without twin-twin transfusion. However, in the setting of evolving twin-twin transfusion, you often get monophasic AV valve inflow Dopplers, reflecting that worsening diastolic dysfunction and increased afterload on the ventricle. The UCSF group has published a fair amount on this and noted that even before Quintero staging 1 and 2, you can see tricuspid inflow pattern changes, and it can actually be used to delineate which one is the evolving donor twin versus which one's the evolving recipient. So this is before, this is at 18 weeks. And here you can see that this is a normal appearing tricuspid valve inflow Doppler. And here in the recipient, without any other changes, according to Quintero staging, you can see that you're getting this fused tricuspid valve inflow Doppler. And that is sort of your tricuspid valve inflow duration worsens in evolving twin-twin transfusion. And you can see there is some difference between stage 1 and stage 2 recipients. This is another case that was at 23 weeks. Here you can see the donor twin. You can see our imaging can be quite challenging on the donor twin since they are a little bit stuck and you don't have that huge pocket of fluid around there, but you can see here that there is normal biventricular systolic function and no evidence of biventricular hypertrophy. When you look at the recipient twin here pre-intervention, you get a sense of the fact that if we scroll back down here, here's your right ventricle. It's looking reasonably thickened. The function is definitely decreased. And similarly, if you look at the left ventricle, sorry, those were reversed. You can also see that that's not working as well. Again, here is your left ventricle, here is your right ventricle. That's just a better look at that function. Already you have a essentially fused, if not maybe partially fused, inflow Doppler. Post-intervention though, and then you can see here 23 and 6, just to 24 and 3, you already have resumption of the normal tricuspid valve inflow Doppler. And when you look at the function, you can see here that the ventricular function has improved post-intervention. The hypertrophy usually takes a little bit longer to resolve, but ultimately does. So as Eyal alluded to, in risk stratification, the Quintero staging actually doesn't include any cardiovascular elements to define twin-twin transfusion syndrome. And the severity of our cardiac findings do not always match the severity of the Quintero stages. There have been proposed other ways to try and predict based on cardiovascular findings, and these include the Cincinnati staging, the cardiovascular profile score, and then the CHOP score. In terms of the Cincinnati staging, here you can see there are scores that you can assign to the donor and the recipient, so including some of the findings that we already see in the Quintero staging, but then here you see the cardiac variables in terms of the cardiomyopathy, the AV valve regurgitation, ventricular hypertrophy, and then the MPI, which is another marker of ventricular function. And you can see that you get scores for each of these. And so here again, you can sort of see how they are proposing staging for this. Similarly, there's the cardiovascular profile score, which again was not specifically developed for twin-twin transfusion. This was defined as an overall marker of cardiac health in fetuses. And so here you can see you get 2 points for each of these if you have no high drops, normal venous Dopplers, a normal CT ratio, and normal cardiac function and arterial Doppler. So it's a score out of 10, and you get deductions for each abnormality. And so again, here are a few that look specifically at cardiac function. And then here's the CHOP score, which again assesses the severity of the recipient cardiomyopathy, and it's composed of 9 echo parameters and 4 ultrasound Doppler parameters. And it's supposed to be used as a continuous variable with a higher score correlating with more severe cardiac involvement. And here they did attempt to correlate these to the Quintero staging. So when you get a cardiovascular score of 1, which is on the milder side, you can see that most of the time that would correlate with a Quintero stage 1. But again, we're still not perfect at this. In terms of the long-term cardiac outcomes, the 10-year cardiac outcomes do appear to be favorable for both the donor and the recipient twins after laser therapy. As demonstrated earlier, the diastolic dysfunction tends to resolve quite quickly after intervention. And as we mentioned, the hypertrophy tends to take a little bit longer.
Thanks, Chris, for this presentation. And before we'll open up for discussion, I want to show a few studies that our team has done to confront those challenges that we still have with twin transfusion syndrome. So first, in terms of the evaluation, we wanted to look into the middle cerebral artery pulsatility index when we're evaluating twins, because this parameter is readily available since we're taking the PSV, and we wanted to see what's the significance of this parameter. We know that in singletons with growth restriction, we use this parameter frequently to describe what's called brain sparing, used to be called brain sparing. So what we saw that in our cohort, no abnormal, we had about 17 to 20% that were with abnormal PI in the MCA, meaning below the 5th percentile for its specific gestational age. And when we looked at this specific group with abnormal PI in the MCA, we saw that it had higher rates of demise compared to those with a normal PI. And this went through both in the period at birth and 30 days after birth. So another parameters that we came up with that should be noted at time of diagnosis that is associated with poor prognosis for those donor fetuses, regardless of growth restriction, just in monochorionic twins with TTTS. The second thing is we wanted to come up with a better predicting model of the overall outcome of those pregnancies. And what we did, we analyzed all the ultrasound parameters that we have at presentation and tried to find which one of them are the most important ones that can predict the dual twin survival rate. And we came up with these 6 parameters to be the most important ones. The first is the donor to be below the 10th percentile, intertwin growth discordance above 25%, donor PI, which I mentioned before in the other study, below the 5th percentile, donor DV PI above the 95th percentile. We used to quote only absent A waves or reversed A waves in the DV for Quintero staging, but actually looking at the PI earlier before the absent is also very important. Anterior placenta and the UA PI above the 95th percentile, again, before absent or reverse end diastolic flow. Each of these parameters has a different weight in predicting, and if more than one of them is there, then we can calculate the exact chance of having dual survival. If we look at some practical example, if we had a case that did not present with any of these 6 parameters, the overall chances for dual survival would be 80%. However, if we have a case with an anterior placenta that had a donor UA above the 95th percentile, a donor DV PI above the 95th percentile, we will have less than 1% chances of dual survival. And this is very important for the families to know and to plan the management ahead. Other challenges that we looked into are the anterior placenta. What do we do if there is no opening, no window that we can go through and look up into the placenta? So there were different management that have been offered. Some suggested a an extreme tilt of the patient or some angles in the scope or even a curved scope, but sometimes it's not necessarily possible when you don't have an avascular entry at all. So we tried to find out a solution for that, and what was proposed by our team and also other teams have described that is that we can do a laparoscopy assisted laser, meaning first we do a laparoscopy, insufflate the abdomen with CO2, and then we kind of tilt the uterus to allow an entry from the posterior portion of the uterus. And what we showed, here you can, what we showed in this, I'm not sure this one goes, but what we showed is that those that underwent the laparoscopy assisted had a very similar outcome to those that had the standard laser. And specifically those with an anterior placenta, we saw higher rates of the ability to complete solemnization. This is to us a parameter of being able to see and coagulate the entire equator. So we concluded that with those specific cases, not only that laparoscopic assisted is a feasible option with similar outcomes, it also allows us better visualization of the equator and better completion of the surgery. I want to skip this, so we'll have a little bit more time for discussion, but I do want to mention this study. What do we do in very early or very late twin transfusion syndrome? And we do recommend sending those patients whenever there's a suspicion of TTTS, whether it's before 16 weeks or after 26 weeks. In this study that we have done, we did a Delphi study or Delphi protocol where we asked experts around the world what would they do in those edges below 16 weeks and above 26 weeks, because it was commonly stated that you would do laser between 16 and 26 weeks. However, what we did see is that it is a viable option to offer laser before 16 weeks, 15 and 16 weeks for extreme stage 3 twin transfusion syndrome or stage 4. We also noted that between 16 and 18 weeks, which is the period that we're not very keen of offering laser because of the high risk of rupturing membrane, separation of the amniotic membrane for the placenta, chorioamniotic separation, we would offer waiting a little bit until it's becoming very advanced, say stage 3 with absent or reversed A waves in the ductus venosus. But up until that stage, it is possible to sit on it and wait a little longer towards 18 weeks. And lastly, 26 weeks is where it was not commonly offered laser before, but now we do offer laser after 26 weeks as well for stage 3 and above, up to 28 weeks even. Okay, so the question is how to recognize which are AV anastomosis while performing the fetoscopic procedure. Great question. When we do the procedure, we have a few parameters that we can look into to diagnose which are arteries and which are veins. First, as I mentioned, the arteries go over the veins. So you can see which vessels go over the others. You know these are arteries. Also, the arteries are deoxygenated, so they will have a darker color than the veins, which would be more red, while the others would be more kind of purple. But it definitely requires a lot of experience, and it's a little complicating at the beginning. So what we usually do, we go from one end, follow the vessel back towards the cord insertion, and then follow them towards the other cord insertion, find the area in the middle where they meet, and coagulate them. I hope this answers. I see another question. As pediatric cardiologist, how frequently do you do fetal scans in normal first study? When do you stop? Chris, do you want me to take that? You want to take that?
I was going to let you take that since once it's a normal first time study, I then defer to the MFM fetal surgeon about when we should see them back if there are other concerns.
Yeah, so our preference is to have the echo whenever we're suspecting twin, and also repeat that after the laser if needed. If we have a say stage 1 and we're thinking should we go in or not, we would use the echo parameters and our colleagues' opinion about the severity of the disease to decide whether to go in or if we can wait a little longer. So there is no exact prescription for that, but I would say at first presentation when we diagnose the twin, we would very much appreciate having an echo parameter. Then we would repeat that usually a week or so, maybe 2 weeks after the laser. And if things look better, we would probably not repeat another echo. Otherwise, we would suggest that again. Our AV connections could be normal. So AV connections are present in any monochorionic pregnancy. They are there. They are not the problem or the reason for us to go in. We would not see them before. By ultrasound, it's very difficult or maybe even impossible to diagnose them. We only see them when we're inside with a scope. So our diagnosis is based on the complications that are being caused, the polyoligo or the abnormal Doppler flows, and then we would go in and coagulate them. When we coagulate them, we'll have to take all of them and separate the placenta into two, kind of dichorionize the placenta because we wouldn't know which of them is the one causing the problem. And even if there is one specific one, if we take that one, now another connection will be unbalanced. So we have to take all the connections. Next question. Is there any use of laser whenever there is an overlap of all the complications in monochorionic gestation, such as the case that you presented, DTTS, FRAP, and SFGR? Yeah, so good question. Many times we're getting those complications together. What will lead our management would be the more acute disease, which is the TTTS. So if you have TTTS stage 2 or above, you would definitely go ahead with laser. We sometimes offer laser for selective fetal growth restriction only as well. I'm sorry that we didn't have time to go through those cases today, but it would be a much more challenging laser, but it's definitely an option not to fix the selective fetal growth restriction, because this is something we cannot fix, but to protect one of the twins or the larger twin from the demise of the smaller twin, if that would happen spontaneously. So in general, just in a nutshell, for selective fetal growth restriction specifically, our treatment is, if needed, most of the cases just require close monitoring, but if indicated, would be either selective reduction to protect the other twin, or selective or laser. So I hope this answers. But again, if you get both TTTS, TAPS, and SFGR, the answer is yes, laser would be the treatment of choice. What is the contemporary role of selective reduction by port occlusion beyond just pregnancies with a major anomaly in one twin? Are there particular poor prognosis situation where you might give the patient a greater chance of a single life birth compared to laser? So this also takes us a little bit more towards selective fetal growth restriction, because that would be the main indication apart from pregnancies with a discordant anomaly, as mentioned here, to recommend selective reduction. Some patients elect to go for selective reduction in cases of twin-twin transfusion syndrome. That's really the minority of our patients because the treatment of choice would be laser with relatively good outcomes and chances to have maybe both twins alive. If we have a case of TTTS that we anticipated to be very technically challenging, say an anterior placenta at 16 weeks and 0 days, for example, with no vascular, avascular area that we can go through, that might be a candidate as well for a selective reduction because we believe the one twin is very sick already, doesn't have high chances of survival, and also the morbidity associated with laser is so high that it might be reasonable to offer a selective reduction specifically for those cases. So I hope this answers the question. And I believe that was the last question. We're also right on time to conclude this meeting. So thank you everyone for joining us. And I hope we answered some of your questions, and we are looking forward to communicate with you further for specific patients and happy to get all the referrals to take care of your patients.